Thank you all for being attending our high rounds today on before an Easter holiday weekend for some of you. But I'm going to be I guess now the second in a long line of people who will be doing some updates from CROI for everyone. So I don't think I need to introduce myself very exhaustively here. Everybody pretty much knows who I am. So I'm Connie Benson. I'm the professor of medicine here at UCSD and work at the AVRC and in HIV related research. I'm also on the program committee and the foundation board for CROI. So I'm going to go ahead and share my screen and get started with the presentation today, reviewing data that I hope will be of interest to everyone. Get rid of all of these various. Okay, so this is Virtual CROI 2021, and I'm going to be talking today about new data on HIV-related co-infections and opportunistic infections. I have no conflicts to declare related to this talk. And by way of introduction, I'm going to start off giving a brief update on the release of Virtual CROI program materials publicly, then move into a presentation related to co-infections that will focus on TB, hepatitis C, hepatitis B, just one presentation on human papillomavirus that I found interesting, and then data on cryptococcal meningitis. I'm specifically not going to be reviewing neurologic complications of HIV or other end organ comorbidities or metabolic complications, because those will be the topic of future discussions by other members of the faculty. And I'm also not going to talk about HIV co-infection together with COVID. There have been a number of reviews already related to that topic, and those data continue to evolve. So you'll hear more about those particular presentations from CROI in future talks. So let's move right into the first topic, which is a brief update on release of Virtual CROI program materials. As many of you know, based on the need for Virtual CROI to require registration in order to access the program materials, that need has been explained in detail in a statement that we released from the CROI Foundation and is posted on the website for those of you who are interested in hearing some of the background about why the presentations weren't made immediately available after each day of the program sessions for Virtual CROI. But I'm happy to report that they will be available to the public starting on April 15th. We needed to transfer all of the programming that had been recorded and updated on a different platform over to a platform that can be searchable by the public on our CROI website. So that will be taking place has been taking place since Virtual CROI ended, and we should be good to go with access to those materials on April 15th. So if you have any questions related to that, please let me know, but you can access the presentations themselves after that date. So I'm going to move right into data related to TB treatment and prevention, as these data were presented at CROI. The first topic I want to talk about is high-dose rifampin. For any of you who've been following the TB literature, particularly the TB literature related to HIV co-infection and severe TB disease, there's been an ongoing effort to explore higher doses of rifampin as one of the core drugs for treatment of tuberculosis. Given the concerns about metabolic and drug level concentrations of rifampin and how those impact other drugs, there's been a lot of attention paid to looking at pharmacokinetics and safety of high dose rifampin in different settings. So one of the studies presented as an oral abstract at CROI was a phase 2b randomized clinical trial, was explored PK and safety of 2 doses of rifampin in 120 patients with newly diagnosed tuberculosis and HIV co-infection. Participants with TB were randomized to a standard of care dose of rifampin, which is 10 milligrams per kilogram per day, or a high dose rifampin schedule of 35 milligrams per kilogram per day. If patients were treatment naive, they were also randomized to either an efavirenz or a dolutegravir-based ART regimen. These 2 ART drugs were used because they are the ones that have had the most experience in the treatment of co-infection with HIV and TB, and are the ones most widely available globally in places where TB is more endemic than in the US. Patients who were already on efavirenz or dolutegravir were continued, but the dolutegravir dose was switched to twice daily dosing. The graphic here depicts the 4 treatment arms: standard of care rifampin with or without dolutegravir or efavirenz, and high dose rifampin with efavirenz or dolutegravir. Just to summarize, the median age for patients enrolled in this study was 36. The CD4 count was 192. About 50% were on ART at the time of enrollment, and the remainder started ART in the randomization, and 92.5% of patients had bacteriologically confirmed tuberculosis. So this is really the money slide in terms of the findings of the study. Grade 3 and 4 adverse events in terms of safety were similar in both the rifampin, in all of the rifampin containing arms. There were 6 serious adverse events reported during the course of the trial, 3 in each of the rifampin plus dolutegravir arms, and none in the rifampin and efavirenz arms. However, none of these serious adverse events resulted in treatment discontinuation or a need for further medical care, and were not directly attributed to the drug, with the exception of 2 of them that may have been attributable to rifampin. Sputum culture conversion by week 8 of intensive treatment was higher in the high dose rifampin arm, 86.2%, compared with the standard dose rifampin arm, 62.9%. This did not reach statistical significance, but you can see graphically depicted here the differences in sputum culture conversion. While high dose rifampin decreased the dolutegravir trough concentrations by 48%, there's a relatively robust therapeutic window for dolutegravir, and virologic suppression was achieved in all of the patients. Efavirenz concentrations were more highly variable, but most patients had therapeutic concentrations, and the authors concluded that the high dose rifampin arm resulted in data suggesting that rifampin in high doses may be safely used with either dolutegravir or efavirenz for TB treatment, and may be associated with a higher treatment response rate. Keeping along the theme of high dose rifampin, another very serious complication of tuberculosis is TB meningitis, and another oral abstract presented at CROI looked at high dose rifampin in this setting. Just by way of background, case fatality rates for TB meningitis in people with HIV infection is reported to be as high as 50% in most studies. We also know from other studies that rifampin doesn't penetrate the CSF very well, and concentrations in the CSF in people with TB meningitis are often undetectable, and some studies suggesting that they are undetectable in up to 2/3 of patients. A meta-analysis of 3 phase 2 clinical trials done in Indonesia, and then another study reported out of Vietnam, showed that increasing rifampin exposure was associated with increased survival in individuals with TB meningitis. So with this background in mind, this study was done to evaluate patients with HIV infection and suspected TB meningitis, and randomized them to rifampin given intravenously in a dose of 20 milligrams per kilogram per day, along with standard of care other TB drugs. Rifampin given PO at 35 milligrams per kilogram per day with standard other TB drugs, and then standard of care rifampin, isoniazid, pyrazinamide, and ethambutol as the control arm. PK sampling was performed as indicated here, and clinical assessments were done at week 4, week 8, and week 24. And this is the, on the left-hand side of your slide, the high dose or the characteristics of the patient population. There's a lot of numbers here, so I'll just briefly summarize that the average age of the patients was around 34 years. There were slightly more men than women, but a pretty close approximation of equal enrollment by sex or gender. And HIV details, 90% to 95% were HIV infected. The small percentage were not HIV infected. And of those who did have HIV, the CD4 count was quite low, an average of around 50 cells per microliter. There, about a quarter of the patients were currently receiving ART, and others were started on ART after the completion of this phase of the study. So just to show you the serum exposure to rifampin based on the 3 treatment arms, the AUC 0 to 24 hours is depicted here. You can see that the control group with 10 milligrams per kilogram per day has quite low serum concentrations compared to the 2 high dose arms, with the highest concentration seen in those receiving 35 milligrams per kilogram per day. This is the more important component of this study, the rifampin CSF concentrations. And just to highlight the key findings here, the percentage of individuals who had detectable CSF levels of rifampin were 100% for the 2 high-dose rifampin arms, and only 44%, or 8 of the patients, had detectable CSF levels with standard of care rifampin dosing. And when you look at this line across here, which is the rifampin MIC for Mycobacterium tuberculosis, in the 2 high-dose arms, 93 to 94% of patients had rifampin concentrations above the MIC, and only 11% of those in the standard of care arm had rifampin concentrations above the MIC for MTB. When you look at adverse events in terms of safety and clinical outcomes, the grade 3, 4, and 5 adverse events were similar and not statistically different across all 3 of the arms. And in fact, elevations of ALT and other complications clinically were more frequent in the control arm than in the 2 high-dose rifampin arms. Looking at pre-specified secondary endpoints, again, the percent with grade 3 to 5 adverse events was higher in the control arm than in the 2 high-dose rifampin arms, although there were no statistically significant differences among these. One point to make here is that the study was small. It was not statistically powered for clinical endpoints or outcomes of TB disease. And in fact, there were no differences by arm in clinical endpoints in the study. And overall, there was a 39% case fatality rate during the 24 weeks of follow-up after onset of TB meningitis treatment. Again, highlighting the point I made earlier about high rates of TB meningitis mortality in people with HIV. So the authors concluded that in the standard RIPE regimen, 56% of patients had undetectable CSF rifampin concentrations, and only 11% had rifampin concentrations above the MIC for MTB. There was greater than proportional increases in rifampin exposure with increased dose levels, and no excess toxicity was observed with either of the higher dose rifampin arms. There was no impact on clinical outcomes, but this is a small study not powered for clinical endpoints, and there is a large randomized clinical trial ongoing right now that we should have results from shortly. The third major study reported at CROI related to TB treatment was the outcome in people with HIV of the rifapentine moxifloxacin short course therapy study. Many of you may have heard the results of this study, although we haven't specifically talked about it at case conference or at high rounds as of yet. But this was a large international phase 3 open label randomized clinical trial in which more than 2,500 patients were enrolled from 13 different countries around the world. The randomization in this study included rifapentine in a dose of 1,200 milligrams per day, which was substituting for the rifampin component of standard of care TB treatment. And this arm was a 4-month treatment arm. The second interventional arm was rifapentine in the same dose plus moxifloxacin, which replaced ethambutol in the regimen, and then added to isoniazid and pyrazinamide for 4 months. And then the control arm was standard RIPE for 6 months. People who were HIV co-infected in this study were treated with an efavirenz-based ART regimen while awaiting more of the dolutegravir data that I've started to show you. And the primary endpoint was TB disease-free survival at 12 months. There were only 214 people with HIV enrolled in the study, and this primarily related to the fact that only efavirenz-based ART could be used in the course of the study. And there were 3 methods for analysis of the primary endpoint of TB disease-free survival. A microbiologically eligible group were patients who had culture-confirmed TB susceptible to study medications. An accessible analysis group were those who were microbiologically eligible, but excluding those who were lost to follow-up, those who were had treatment discontinued due to pregnancy, to death, or death due to a violent or accidental death during TB treatment, or had TB reinfection. And then the per protocol 95 analysis included accessible patients who completed at least 95% of assigned treatment. So this slide shows you the differences in these 3 analysis parameters, or at least one of these analysis parameters for the microbiologically eligible population, and is meant to highlight the point that there were not major differences between the HIV seropositive group and the HIV seronegative group in the overall parent study. The only major differences, although again, these were not statistically significant differences, was a slightly higher preponderance of people of men in the HIV negative group, and more patients with diabetes as an underlying comorbidity in the HIV negative group, and a more overrepresentation of Black or African American patients in the HIV seropositive group. The 3 measures of outcome are listed here, and this is now only for the patients with HIV group, and looking at microbiologically eligible, accessible, and per protocol 95 analyses. All of these favored either the control arm or the rifapentine moxifloxacin arm. The safety outcomes, primary safety outcome, as indicated in other studies, the control arm had higher rates of grade 3 to 5 adverse events than either of the 2 interventional arms, and higher rates of serious adverse events in the control arm as well. So in conclusion, the authors demonstrated, as did the overall parent protocol, that the efficacy of the 4-month regimen of rifapentine, moxifloxacin, isoniazid, and pyrazinamide was non-inferior to the 6-month control arm of standard RIPE. and the 4-month rifapentine arm did not meet the non-inferiority criteria. There was no evidence of an interaction between HIV status and treatment arm, and both investigational regimens were safe compared to the control arm. The overall 2,500 person study had similar results, and these data suggest that the rifapentine moxifloxacin 4-month regimen is a viable option for shorter course treatment of TB in people with HIV. So the next study I'm going to talk about is the last TB trial, for those of you who are getting bored with TB. And this one was a report of pregnancy outcomes among women who were taking INH in the BRIEF TB study. If you will recall, the BRIEF TB study was an AIDS clinical trials group study that evaluated 9 months of isoniazid compared with 1 month of isoniazid plus rifapentine for prevention of TB in high-risk populations in international settings or people with confirmed latent TB infection. The women enrolled in the BRIEF TB trial who were not on the 1 HP arm were followed in this pregnancy outcome study. Those who were in the 1 HP arm were excluded because the contraceptive requirements for enrollment in that arm precluded pregnancy, and there were no pregnancies in that arm. So we're now talking about the analysis of patients who were enrolled at age 13 years or above who experienced pregnancy during follow-up on the 9-month isoniazid arm. Evaluations were done, as you can see, according to this schedule, and data were collected specifically in a pregnancy outcome case report form. So just by way of background, there were 3 definitions used in this study for defining INH exposure. The definite exposure were those individuals who had a positive pregnancy test or a pregnancy outcome evaluable on or before the last dose of isoniazid in the study, or an estimation of the start of pregnancy based on gestational age at birth while on INH. Possible exposure was listed when individuals didn't have documentation of these intervals, and then not exposed were individuals who had a pregnancy outcome that occurred beyond 45 weeks after the last dose of INH, or if within 45 weeks of exposure was deemed outside the window of INH exposure. So this is the consort diagram just showing you that in the overall study, which enrolled 3,000 patients, 1,614 of them were female participants. 812 of those were randomized to the isoniazid arm, and 136 women became pregnant on study. 8 women had an unknown pregnancy outcome, and this left analysis to 128 women with a known pregnancy outcome. 89 of these were deemed to be not exposed to INH at the time they became pregnant. So they became pregnant after their last dose of INH in follow-up, and 39 women who were exposed during INH treatment. This pie chart just shows you the different countries and representation of women enrolled in the trial. And as you can see, sub-Saharan Africa was the most common geographic locale for the individuals enrolled in the study. These are the study population characteristics for INH exposed and non-exposed, and just briefly showing you that the CD4 counts and ART at entry and other pregnancy outcome ART at enrollment and pregnancy exposure listed here. There were no substantial differences between the INH exposed and non-exposed, with the exception of ART at the time of pregnancy outcome, with many of the women receiving efavirenz-based ART at that point as well. So this is the result of the study showing non-live birth outcome occurring more commonly in those who had INH exposure during pregnancy. So a rate of 41% of women experiencing a non-live birth outcome in the INH exposed arm compared to the unexposed arm. And the type of non-live birth outcome was spontaneous abortion for the majority of these, although there were a few individuals who had induced abortions or stillbirths. And looking at the significance of the increase in non-live birth due to isoniazid exposure, you can see that in an adjusted analysis, the risk rate for non-live birth was almost twofold higher for people exposed to isoniazid. And the conclusion from the study was that INH exposure, which occurred mainly during the first trimester of pregnancy, was associated with an increased proportion of non-live births, mostly spontaneous abortions, and these support other observations from both animal studies and recent impact clinical trial that also reported adverse birth outcomes after exposure to isoniazid isoniazid during pregnancy. And the authors suggest that women of reproductive age should be counseled about the relative risks and benefits of INH if they require INH usage for treatment of latent tuberculosis infection. And there's also the potential need for adequate contraception while on INH to avoid first trimester exposure. I'm now going to go on to talk about hepatitis co-infections. And the first study that I found interesting was an oral presentation about hepatocellular carcinoma in people with HIV and chronic hepatitis B infection. As you all know, chronic hepatitis B infection is the predominant cause of hepatocellular carcinoma worldwide and is a leading cause of cancer deaths. The study objective for this study, and I'll remind everyone that Lalo Kashai was one of the authors of this study, so if he has comments, we'll be happy to have him talk further about these. But the study objective was to identify the determinants of hepatocellular carcinoma in the NA Accord cohort, which is a large multi-center, multi-cohort study that is sponsored by the NIH and has been ongoing for almost a decade now, evaluating persons with HIV and HBV co-infection. The risk factors that were evaluated are listed here, and they were a combination of HIV specific, HBV specific, and traditional risk factors for hepatocellular carcinoma. The study population were participants who had been followed in clinical care from January of 1995 through December of 2016 and had chronic HBV infection, HIV, RNA, and CD4 counts available. And just to highlight that those who had prior hepatocellular carcinoma before entry or acute HBV diagnosed within 30 days of follow-up were not included in the study. So the risk factors, data analysis and patient follow-up is just graphically depicted here. Censoring events included death, ending follow-up in the cohort, or a report of HCC diagnoses or loss to follow-up before December 2016. The characteristics for the patients, and there were 8,354 patients analyzed in this study, are shown here. And you can see it's a pretty diverse population with both demographic background and underlying comorbidities, including underlying chronic hepatitis C. And the characteristics of HBV DNA testing indicate that the majority of patients had detectable, that the majority of patients who were tested had either levels above 200 or below 200 international units per ml as a cutoff. About 55% had undetectable HBV DNA, and about 45% had higher quantitative or qualitative HBV DNA measured. About half were E antigen positive, and about 76% were receiving HBV active antiretroviral therapy. So looking at the risk of hepatocellular carcinoma based on quantitative HBV DNA and the duration of HBV suppression is really the key findings of this study. And looking at undetectable levels of HBV DNA as the reference, you can see that any detectable HBV DNA level increased the risk of hepatocellular carcinoma by about 2 to 3-fold, with the highest risk seen in those who had high levels of HBV DNA. Likewise, the duration of HBV suppression on antiviral therapy also affected risk, with those who had undetectable levels of HBV or HBV suppression of less than a year having a higher risk of hepatocellular carcinoma occurring than those who had undetectable or HBV suppression for a year or more. And the lowest risk was seen in those who had 4 or more years of undetectable HBV DNA, or basically those who were fully suppressed on HBV active antiretroviral therapy. Looking just at traditional risk factors for hepatocellular carcinoma in HIV co-infection, you can also see that age, heavy alcohol use, chronic HCV co-infection all contributed to risk of hepatocellular carcinoma, as you would expect. And the conclusions by the authors were that any level of HBV viremia increased the risk of hepatocellular carcinoma. Antiviral therapy reduced but did not eliminate that risk, and therefore concluding that HBV DNA surveillance, optimizing HBV suppression, and the durability of that suppression will be key to preventing hepatocellular carcinoma in people with chronic HBV infection and HIV co-infection. So now I'm going to turn to hepatitis C. And as you know, WHO has set a goal for elimination of hepatitis C with more than 90% reduction in new HCV cases by 2030 as a goal. And HBCV elimination goals will depend not just on active treatment with pan-genotypic direct-acting antiviral agents, but identifying and treating everybody who has HCV infection. So this was a nice study also done by our group here at UCSD with Antoine Chelon and Natasha Martin taking the lead. And this was applying a cost effectiveness model of different strategies for testing of HCV prevalence in MSM, using a model that was adapted from the United Kingdom to apply to MSM in the United States. The assumptions incorporated in the model were that 15% HIV prevalence among MSM, 8% HCV prevalence, 25% PrEP coverage among MSM without HIV, and HCV testing frequency for MSM with HIV every 2 years, and without HIV only when HCV symptoms occurred. So these were the background assumptions that were incorporated into the model. They then looked at the cost effectiveness of different strategies for testing MSM. And looking at the 3 strategies that they evaluated, they looked at MSM with HIV, testing for hepatitis C every 6 months. For MSM who are using PrEP, you're doing antibody testing every 3, 6, or 12 months. And for PrEP non-users, doing antibody testing when they tested for HIV. And although you may find this slide a little bit difficult to read in terms of the small print, you can see that 3 of their approaches were highly cost effective in the surveillance strategy for hepatitis C testing. And overall, those 3 strategies included evaluating PrEP non-users when and testing them for hepatitis C when they were tested for HIV was highly cost effective. Taking PrEP non-users when they were tested for HIV and then adding PrEP users being tested every 12 months was still cost effective. And then adding into the model PrEP non-users being tested when they were HIV tested, PrEP users being tested once annually, and HIV infected MSM being tested every 6 months was also highly cost effective. When you went beyond that with more frequent testing, the cost effectiveness dropped off. And overall, the authors concluded that HCV elimination can be achieved among MSM in the US by a relatively nominal and logistically feasible cost-effective increase in the frequency of HCV screening. And based on this model, would recommend that MSM with HIV be tested every 6 months for hepatitis C. MSM who are using PrEP but are not HIV infected be tested for HCV annually, and MSM who are not using PrEP and are not HIV infected be tested for HCV at any time that they are also tested for HIV. So in the spirit of HIV or HCV testing, there was another study presented in a short Science Spotlight poster presentation looking at HCV self-testing. And this was an evaluation of self-testing at home with and evaluating the usability and acceptability of an OraSure type technology oral fluid self-test. This was a pilot observational series of studies that assessed individuals in Egypt, Kenya, Vietnam, the Republic of Georgia, and China in an effort to increase at low cost HCV surveillance as part of the plan for HCV elimination. And this slide depicts the overall results across the entire study. And I'm only going to highlight not a lot of the data here, but the usability and acceptability and the correct interpretation of results and inter-operator agreement here for the different countries in which the study was done and the different types of patient populations. And I think it suffices it to say that overall, the results were generally interpreted correctly by the users, and there was a great deal of inter-operator agreement among the users who were doing self-testing. And the majority of individuals, although there was some geographic variability here, would use self-testing again and considered self-testing to be a relatively easy procedure to follow. So we may hear more about the use of HCV self-testing as a way to expand our HCV testing as we work our way toward HCV elimination. And then the last study I want to talk about related to HCV is one we've been doing here at UCSD and has several of our UCSD investigators involved. And this was a 5360, an ACTG study referred to as the MIN-MON study, meaning minimal monitoring as an approach to hepatitis C treatment. The study objective here was to evaluate the efficacy and safety of a minimal monitoring approach to deliver HCV therapy. The study design was a phase 4 open label international single arm trial. 400 participants were enrolled at 38 ACTG international sites and included the US. The study drugs were a pan-genotypic direct-acting antiviral therapy that included sofosbuvir in a dose of 400 milligrams per day and velpatasvir 100 milligrams per day in a fixed dose combination. And this was given once daily for 12 weeks. The study population included adults who were HCV RNA positive and had no prior HCV treatment, and compensated cirrhosis was allowed. HIV co-infection was present in 42% of the population, and 99% of those who were HIV co-infected were suppressed on antiretroviral therapy. This is the overall approach that was used. The Min-Mon approach included no pre-treatment genotyping. All 84 tablets were dispensed at entry. There were no scheduled on-treatment clinical or laboratory assessments. There was a remote contact by telephone or video visit at week 4 and week 22. And then patients came in at week 24 for a sustained virologic response visit to have blood drawn to determine that as an endpoint. The Min-Mon approach was highly effective in maintaining contact with patients. The week 4 remote contact took place in 99% of patients, and the week 22 in 84% of patients. There were a few participants who reported losing study medications or prematurely, there was only one participant who prematurely discontinued treatment due to an adverse event. There were 21 unplanned visits among 15 participants, but only 3 of those were for an adverse event, 8 of those for abnormal lab values at baseline, and 6 had non-adverse event clinical events. The overall sustained virologic response reported from the study was 95%, here depicted in green. And the 20 patients who were considered to be non-responders, 10% of those were non-responders because they were lost to follow-up. The majority of those were HCV genotype 1, and among the non-responders, 67% had self-reported full adherence to the regimen. So this was considered to be highly successful in terms of overall efficacy. I've highlighted a couple of points about safety already. There was at least one serious adverse event in 14 of 397 patients, but only 5 of those occurred while on study medication, and none of those were related to study treatment or resulted in discontinuation of study treatment or death. There were grade 3 and 4 toxicities that occurred in 14 patients overall. And none of these were considered to be treatment related. The limitations of this study were obvious. There's no control arm. This was a select subset of individuals with HIV co-infection who were already suppressed on antiretroviral therapy, so generalizability to patients who are not suppressed or people who have a difficulty adhering to antiretroviral therapy or other therapies, it may not be suitable candidates for this approach. And we had no sequence data on non-responders. But the authors concluded that the Min-Mon approach to HCV treatment with this fixed dose combination was simple, safe, low cost, and achieved SVR comparable to rates in current clinical practice for HCV treatment of naive persons without decompensated cirrhosis. Next, I'm going to go on to cryptococcal meningitis as an opportunistic infection. There were only 3 studies presented at CROI on cryptococcal meningitis, 2 of which related to cryptococcal antigen testing, and we've already gone over in detail the benefits of surveillance using cryptococcal antigen and preemptive therapy for people at high risk for cryptococcal meningitis, so I decided not to review those again. But another interesting study was a retrospective analysis from another of the large NIH-funded cohort studies for people with HIV, the IDEA cohorts, and these are international cohorts as opposed to the NA Accord, which is a US-based cohort evaluating patients being followed in clinical practice on antiretroviral therapy. And this particular retrospective analysis evaluated people with HIV who had been enrolled in clinical care from 1996 through 2017 and evaluated the overall incidence of cryptococcal meningitis and all-cause mortality after the global expansion and implementation of antiretroviral therapy. There were 819,641 people with HIV included in the study. The median follow-up was about 3 years, and 3,961 patients, or about 0.5% of the overall cohort, were diagnosed with cryptococcal meningitis over time. And you can see the crude estimates of incidence, although some of these with broad confidence intervals, around the geographic areas that were included in the IDEA cohort. So the highest rates of cryptococcal meningitis were reported in Latin America and East Africa, slightly lower rates in North America, and interestingly, lower incidence in Southern Africa of cryptococcal meningitis. And Asia Pacific numbers were small here, but particularly wide confidence intervals in terms of the overall incidence. 65% of cases of cryptococcal meningitis occurred after the start of antiretroviral therapy in this cohort, and the median time of onset or diagnosis of cryptococcal meningitis was 255 days after the start of antiretroviral therapy. The overall unadjusted incidence of cryptococcal meningitis across the entire cohort was 1.15 per 1,000 person years, but this varied depending on when in follow-up patients were engaged in the cohort. The incidence in the year 2000 was 1.46 per 1,000 person years and had declined to 0.62 by 2015. Looking at incidence rate ratios for diagnosis by risk factors, you can see that CD4 count, and in this case, CD4 count below 200 was associated with a higher incidence rate, and being on ART and being diagnosed in a more recent year was associated with a lower incident rate ratio for cryptococcal meningitis. Likewise, all-cause mortality after a cryptococcal meningitis diagnosis was also related to CD4 count, and in this case, age and year of diagnosis. So overall, the authors concluded that 31% of people with diagnosed cryptococcal meningitis died as a consequence of either higher mortality related to cryptococcal meningitis or all-cause mortality following that diagnosis. Some of these data may be impacted by the fact that 35% of those diagnosed with cryptococcal meningitis were lost to follow-up. So some of these numbers may be different had we been able to find all of the patients with the diagnosis. Higher CD4 cell count, being on antiretroviral therapy, and more recent year of follow-up were all associated with a decreased incidence of cryptococcal meningitis. And while higher CD4 cell count, younger age, and more recent year of diagnosis were also associated with a decrease in all-cause mortality after cryptococcal meningitis diagnosis. And lastly, the authors concluded that while the incidence of cryptococcal meningitis has significantly decreased over time, it is not it has not decreased completely, and ART alone did not completely eliminate the risk of cryptococcal meningitis. In this last study I'm going to cover in the last couple of minutes here related to human papillomavirus, not because it's a particularly earth-shattering study, but because it highlights a point that I wanted to make about monitoring women with HPV and the potential for cervical intraepithelial neoplasia or precancerous cervical carcinoma lesions. By way of background, women with HIV are known to be at higher risk for cervical intraepithelial neoplasia. They are at higher risk for treatment failure when they have high-grade CIN compared with women who do not have HIV co-infection. And HPV 16 and 18 genotypes are those most closely associated both with high-grade cervical lesions and with treatment failure as a consequence of treatment for high-risk cervical lesions. So given that background, investigators in Sweden used a combination of efforts to find all of the HIV-infected women with cervical intraepithelial neoplasia over a snapshot period of time using the Swedish National HIV, cervical screening and population registries. They were able to identify 116 women with HIV and matched them with 226 women without HIV who had CIN2, or high-grade cervical intraepithelial neoplasia. They obtained tissue blocks and genotyped these for human papillomavirus, and were able to identify that, as expected, HPV-16 was the most common pretreatment genotype associated with CIN2 and with treatment failure among the women with HIV. But interestingly, they also identified HPV genotype 35, which has not previously been shown to be associated with CIN2 and treatment failure. And this genotype was present mainly in women who were born in sub-Saharan Africa. And for those women who had HPV 16, 18 pretreatment HPV types, they were 3 times more likely to have treatment failure if they were HIV infected and had those pretreatment genotypes than women without HIV and those genotypes, with a 2.6-fold increased odds ratio for treatment failure. Women with HIV and non-HPV 16 and 18 pretreatment genotypes were 7 times more likely to have CIN2 and treatment failure than women without HIV in those genotypes. So the authors concluded that HPV 35 is a newly identified genotype associated with CIN2 treatment failure among women with HIV. This is not a genotype that's included in current HPV vaccines, and highlights the need for continued surveillance and post-treatment follow-up, irrespective of HPV vaccination or genotype, for women who are at risk for cervical intraepithelial neoplasia and cervical cancer. So I'm going to stop here and leave some time for questions. In summary, co-infections and opportunistic infections are a relatively small component of CROI these days, but they continue to adversely affect quality of life for many people living with HIV around the globe. New research continues to take place and has helped to move the field forward in reducing this adverse impact on quality of life. Key points to take away from the data that were presented at CROI this year related to co-infections. The first is that we are approaching consensus that the dose of rifampin should be higher in treating active tuberculosis, especially in those with severe TB and TB meningitis and people with HIV co-infection. A 4-month regimen that included rifapentine and moxifloxacin together with INH and PZA was as effective as 6 months of standard of care for TB treatment in both HIV uninfected and people living with HIV, and may become shortly the standard of care for treatment of TB. More evidence has been accumulating of the negative impact of isoniazid on pregnancy outcomes, raising concern about the need for counseling women of reproductive age when they need to receive isoniazid therapy. Persistent HBV viremia increases the risk for hepatocellular carcinoma and is not fully mitigated by antiviral therapy in people with HIV, so that surveillance of HBV DNA levels and close attention to active antiviral agents that are effective against HBV will help to reduce the risk for hepatocellular carcinoma. HCV elimination goals will require both the direct treatment for HCV, but also more effective testing strategies. Self-testing may be a viable option, and we can reduce the cost of HCV treatment by minimizing laboratory and in-person monitoring, making both testing and treatment more globally widely available. And then lastly, while the incidence of cryptococcal meningitis has decreased, ART alone does not eliminate that risk. And in women with HIV, A non-vaccine genotype HPV-35 also increases the risk of precancerous disease and treatment failure as a consequence of precancerous cervical disease in HIV-infected women. So I'll stop there and thank you for your attention and turn it over for questions.
Hi, Connie, it's Gigi.
Hi, Gigi.
Hi, thanks for an outstanding talk. So my question is about the ladies with the and HPV. And so do you think there'll be any change to the current guidelines for screening?
I couldn't really hear your whole question, Gigi. There was a lot of background noise. I'm sorry.
No, that's okay. Can you hear me now?
Yeah.
Okay. So the question is, do you think there'll be any change to the guidelines for screening for cervical cancer?
Well, I think this was a pretty carefully done study. I don't know that it will rise to the level of changing guidance yet, but I think that guidance is in evolution. I think the one key point I sort of found interesting in the study was the fact that other genotypes may be associated with adverse outcomes, particularly for women with HIV infection. And so it may just highlight the importance of post-treatment surveillance and despite prior HPV vaccination and the need for continued follow-up of women who've had any precancerous lesions.
Okay, thanks.
Sure. Okay, so I guess everything was very, very clear, or people are tired and want to get back to work. So I'm happy to answer any additional questions. There will be more to come on CROI 2020 and outcomes from additional studies. And we hope to continue to make these available for you through high rounds in the near future. I just wanted to make one point because it's a little bit of an advertisement for future high rounds. I didn't cover, there was a whole session on hepatitis C and HIV in organ transplantation, and I didn't cover those presentations because we've recruited Saima Aslam to do a whole high rounds on HIV and transplantation coming up in the fall. And so I think it will be important for people to hear Saima's discussion. And so I'll just thank you for all of your attention. There was one comment by Nettie in the chat room about people using 1HP. I think this can be to everyone in attendance. I think people have not been using it because the US guidelines for treatment of latent tuberculosis infection have not recommended 1HP. And there's been a lot of controversy over this, but the primary reason I understand from my colleagues who were involved in the preparation of that guidelines document is that they did not feel that there were enough patients from the US who had documented positive tuberculin skin test or interferon gamma release assays in that study to warrant making that a US recommendation. I personally think it would be a great thing to do, that it was highly effective and no toxicities were observed. However, I will say that there are 2 ongoing studies looking at the drug-drug interactions between dolutegravir and rifapentine. And although it's only a 1-month course, we want to make sure that patients have effective antiretroviral therapy while they're receiving the 1-month HP regimen. And then Nettie is also asking if the new data on rifampin dosing applies to rifampin use for latent tuberculosis infection. No, I don't think we can make that assumption at this point in time, Nettie. These high dose rifampin recommendations really relate to treatment of active TB, and whether it's necessary to use higher doses in latent TB infection has not been evaluated. And then Sanjay asked whether higher doses of rifampin affect induction of cytochrome P450 enzymes. So the one point I made in the first TB presentation, Sanjay, was that while when looking at efavirenz and dolutegravir specifically, the higher doses are associated with higher induction of CYP3A4 enzymes related to dolutegravir and efavirenz, but did not reduce concentrations of those drugs sufficiently to warrant changing doses of those drugs away from what's already recommended in the setting of rifampin. I think it remains to be seen whether induction of cytochrome P450 enzymes by rifampin will affect other drugs that use that metabolic pathway when you use higher doses. But I think it really does highlight the need in terms of outcomes for more severe TB disease. And what we may wind up recommending is that we use higher doses for TB meningitis specifically, and maybe not for standard TB disease, drug susceptible TB disease. But I think what we are learning is that higher doses are safe in terms of adverse events and certainly result in higher concentrations in the serum and in the CSF of rifampin. And then Lalo, commenting on the MinMon study, suggesting that one model does not fit all. I would agree with that, Lalo. 10% loss to follow-up in a well-selected population is certainly a problem. And I think that that doesn't represent, I may have misstated that, but 10% loss to follow-up was only among those who were non-responders, not the whole cohort. So, and I think the reason for the non-response rate in those 20 individuals, it basically means that 10 individuals were lost to follow-up across the whole cohort. And the 10 of those were in the people who were evaluated as being non-responders. Okay. I think we are beyond the top of the hour. So thank you all for your attention, and we look forward to more CROI updates and future conferences. Have a great day, everybody, and a great Easter weekend for those of you celebrating the holiday.